We have discussed the first section in the excretory system, and that is the renal circulation and JJ apparatus, nephron. Now we will see the major section, which has the conceptual discussion involved. Let's begin with the first part, a small concept, and that's clearance. The questions that have come from this small section, the clearance. For example, in the clearance equation UV upon P, what is U? That's a question. And the options given are urinary concentration of a substance in milligram percent, or urinary concentration of a substance in milligram per ml, or urinary concentration of a substance in ml per minute, or urine volume, urine flow rate. So, what is U and what is the unit for it? That's a question which has been asked. So, let's understand the concept of clearance. Basically, it's defined as, now look at the definition, it's a slightly convoluted definition. It says clearance is the theoretical volume of plasma or notional volume of plasma or hypothetical volume of plasma that is completely cleared of a substance per unit time. That's the definition. Now, what does it mean really? It means a kidney will take 1 liter plasma and completely remove a substance from it, that particular substance. Then it takes the next 1 liter of plasma and completely remove the substance from that substance from it. So, that is the definition. Now, let's put it simplistically. Clearance equation is UV upon P, just as we mentioned. So, a substance is present in the plasma and therefore plasma is in the denominator, and how much of it comes into the urine per unit time, that's in the numerator, U into V. That is basically the clearance. Means substance is present in the plasma and then how much of it comes into the urine per unit time. This is the clearance. How much is being cleared per unit time from the plasma. That's the clearance. Let's say this substance X. The equation is Ux into V upon Px, where, well, let's write it here, clearance of a substance X is equal to this. In this, Ux is urinary concentration of X in milligram per ml. That is, in every 1 ml of urine, how much substance? That's Ux. Okay. So, that was the answer to the MCQ. Then V is, or rather we will take the other one, Px is plasma concentration of the substance X. And plasma concentration of any substance is always taken as milligram percent or milligram per deciliter or milligram per 100 ml. Therefore, it will be milligram percent, and V is urine volume, volume of urine per unit time, or also called as urine flow rate. and that will be ml per unit time. Let's take it per minute, it could be per hour, per day. So that's volume of urine or urine flow rate, right? Let's try to understand this further. Ux into V upon Px, that's the clearance of this substance. So what is Ux? Urinary concentration of the substance X in milligram per ml. Milligram per ml. Let's take some hypothetical values, arbitrary values. Let's say 2 milligram per ml. That's the urinary concentration of the substance. And total volume of urine, let's say 100 ml per minute. That's the urine flow rate per unit time. That means in this, the numerator would be, see, in every 1 ml of urine, 2 milligram substance is being excreted. That means in the 100 ml urine, how much will be excreted? 100 into 2, that's 200 milligrams, isn't it? In every 1 ml urine, 2 milligram substance is being excreted, that particular substance X. So in 100 ml urine, how much? 200 milligram, 200 milligrams per minute. That would be the numerator, isn't it? That means the substance will be excreted at the rate of 200 milligrams every minute, right? Now that's clear. So that means it is the, let's write it down. What is the meaning of Ux into V? What is the meaning of numerator? Total excretion rate of the substance. It will be the total excretion rate of that substance in milligram per minute, or let's say per unit time. Excretion rate of that substance per unit time, per minute, per hour, per day, whatever unit we are taking, right? So I want you to keep this in mind as a concept. How do you calculate the total excretion rate of that substance per unit time is urinary concentration of that substance into total volume of urine, obviously. So that much will be the total excretion rate. That's how the substance is excreted every minute or every hour or every day. And what is the denominator? It's the plasma concentration of X. So finally we can say, what is clearance? Clearance is the ratio actually. It's the ratio of, or ratio between total excretion rate of that substance per unit time to its plasma concentration, which is at the denominator, right? Okay. But then what you should note here is that the numerator and denominator, their units are not the same. Numerator is milligrams per minute and denominator is milligram percent. That should be noted clearly. So this is the ratio of total excretion rate of that substance per unit time to its plasma concentration, right? So simply speaking, this much was there in the plasma, this much concentration was there in the plasma, and from that this much is coming into the urine per unit time. That's in the numerator. So that's the ratio really, and that's the concept of clearance. Well, we will be requiring all this information throughout this chapter and maybe even later on in some other sections. So you must clearly understand all these units. Okay, that was clearance. Let's now talk about the glomerular filtration rate, GFR. Basically, we will be discussing two major aspects of it. Factors determining and influencing the GFR, and measurement of GFR. These will be the two things which we will mainly discuss in this particular section. And what question has been asked in this particular section, on this particular section? For instance, in a patient suspected of renal failure, the creatinine clearance was found to be 135 ml per minute. Creatinine clearance in a patient was found to be 135 ml per minute. How much will be his GFR? And the options are 125 ml per minute, 130 ml per minute, 135 ml per minute, 140 ml per minute. You want to answer that just now? Okay, the answer is 130. Why? We will discuss it. Creatinine clearance is an overestimate of the actual GFR. So, we will see that in some time. Okay, and then the other simple questions, fact-based questions. For instance, the best substance to measure the GFR is, and the options are inulin, creatinine, PAH, mannitol. What is the best? Inulin, yes. And the substance most commonly used actually to measure the GFR is, and take same four options, inulin, creatinine, PAH or mannitol. The answer this time would be creatinine. Why is that? We will see all this in the coming chapter, in this section. Okay, so let's start. First of all, glomerular filtration, this is just introduction. Glomerular filtration is called as ultrafiltration. Glomerular filtrate is an ultrafiltrate. Why? You know, the filtration which occurs under pressure is called as the ultrafiltrate. So, glomerular filtration which is happening under pressure, the Starling's forces and the pressures, therefore, it is the ultrafiltrate. And as you are already aware that afferent arteriole brings the blood into the glomerulus, which is a tuft of capillaries, and then the substances are filtered out and the remaining blood will go into the efferent arteriole. So, let's first see the factors determining the GFR. Factors determining. We are talking about the Starling's forces, essentially the Starling's equilibrium or the Starling's forces involved in the filtration process. I want to just recall from the previous chapter, or you may just refer to the chapter where we have discussed these forces, that basically there are two pressures which are involved in the filtration of substances in and around the capillaries. One was capillary hydrostatic pressure and the other one was colloid oncotic pressure. We have done this already in the CVS. So, these will be the and therefore, if you remember, let me just draw it here. Let's say here is a capillary and any accumulated fluid exerts the hydrostatic pressure. So, we have capillary hydrostatic pressure which will force the fluid out of the capillaries, but outside the capillaries there is interstitial fluid which is also an accumulated fluid. So, it will exert interstitial fluid hydrostatic pressure which will force the fluid back into the capillaries. Remember, we have done this already, that hydrostatic pressure is a force that pushes the fluid away out of that compartment into the neighboring compartment. So, capillary hydrostatic pressure will force the fluid out, it will cause the filtration out of the capillaries, and interstitial fluid hydrostatic pressure will force the fluid back into the capillaries. So, it is an opposing force for filtration. Then we also have plasma colloid oncotic pressure or osmotic pressure. Here is a force which is exerted by the proteins. Colloid oncotic pressure is exerted by the proteins. Yes. So plasma proteins are exerting plasma colloid oncotic pressure, and here is a force that pulls the water towards it by osmosis. So plasma colloid oncotic pressure will pull the water or filtrate back into the capillaries, whereas in the interstitium there is interstitial fluid colloid oncotic pressure, because in most of the tissues, I am not talking about the kidney here, okay, in most of the tissues, the proteins do get filtered out into the interstitium, and therefore there will be proteins in the interstitial fluid, and they will exert what is called as interstitial fluid colloid oncotic pressure, and this force will pull the water towards it by osmosis, means out of the capillaries, means it will help in the filtration. This will be an additive factor for filtration. So that was the case in all other tissues. Let's apply these forces or pressures now in the glomerular capillaries in the context of GFR, glomerular filtration rate. There is one force that favors the filtration at the capillaries. The factor that favors the filtration at the glomerular capillaries, it is glomerular capillary hydrostatic pressure. And if you remember from the CVS chapter, you must refer to the CVS chapter because we have done this there in detail. We saw in that chapter that elsewhere in the body, the capillary hydrostatic pressure in all other tissues, it is about 15 to 20 mm of Hg. In the glomerular capillaries, it is 3 to 4 times that. So it will be 60 mm of Hg. Look, it is 60 to 75. Some authors also claim it to be 75. Let's say 60 mm of Hg is a force that favors the filtration. And then there are two forces or two pressures which oppose the filtration. Means they will tend to cause the movement back into the capillaries. What are those forces then? One is plasma colloid oncotic pressure. It is 32 mm of Hg. And the other one is, look, in the case of glomerulus, when the filtration happens, the fluid comes in the Bowman's capsule and the fluid accumulates here. So that fluid will exert Bowman's capsule hydrostatic pressure. And as we know already that the hydrostatic pressure is the force that pushes the fluid back into the capillaries. Fluid which is outside the capillaries, it has hydrostatic pressure and it will force the fluid back into the capillaries, right? So Bowman's capsule hydrostatic pressure is the force which is opposing the filtration because it is sending the fluid back into the capillaries, and this pressure is about 18 mm of Hg. So look at this and calculate how much is the total opposing force. It opposes the filtration. How much is the total opposing force? 32 plus 18, and that is 50 mm of Hg. By the way, you must have noted one point by now that when we discuss the Starling's forces elsewhere in the body, in all other tissues, we talked about the 4 forces which are acting in and around the capillaries. And here there are only 3. Where is the 4th one? The interstitial fluid colloid oncotic pressure. That is missing here. There is no Bowman's capsule colloid oncotic pressure. And why is that? You got it. Yes, because proteins do not get filtered. Normally, proteins do not get filtered out of the capillaries, out of the glomerular capillaries. Elsewhere in the body, the proteins do come out of the capillaries. But in the glomerular capillaries, because of the negative charges on the basement membrane and because of the large size of the proteins do not get filtered out of the glomerular capillaries to come into the Bowman's capsule. So therefore, there is no Bowman's capsule colloid oncotic pressure. Okay, and therefore there are only 3 instead of 4. Right. Now coming to this, there is one factor that favors the filtration, and that is 60 mm of Hg, and there are 2 factors put together which oppose the filtration. If they are put together, it's 50 mm of Hg. So there is something called as net filtration pressure, also called as effective filtration pressure. Look, the favoring pressure is 60 and the opposing pressure is 50. Therefore, net filtration pressure that actually causes the filtration is plus 10 mm of Hg, which actually causes the filtration at the glomerulus. So that's the net or effective filtration pressure. Next point. What is capillary filtration coefficient? In the previous section, I mentioned this, that you will have to by heart it. Capillary filtration coefficient is the rate at which the capillaries filter out the fluids and the substances. In the case of glomerular capillaries, I had mentioned it that it is highest in the body, in the glomerular capillaries. It is 12.5 ml per minute per mm of Hg. Remember? Okay. That means for every 1 mm of Hg of net filtration pressure, in 1 minute 12.5 ml filtrate will be formed. So then how much is the net filtration pressure? 10 mm of Hg. So for 10 mm of Hg, how much filtrate will form every minute? 12.5 into 10, and that's 125 ml per minute. That is the normal GFR, 125 ml per minute, or 180 liters per day if we convert minute into day. I mean this is per unit time, right? So that's the normal glomerular filtration rate. Let's also look at one more entity related to this, and that is filtration fraction. Filtration fraction. Look, you remember what is the renal blood flow? We have seen this already. The normal renal blood flow is about 25% of the cardiac output. So if we take cardiac output to be 5 liters per minute, 25% of 5 liters would be about 1250 ml per minute. That's the normal renal blood flow. But so far as the filtration is concerned, filtrate comes out of the plasma. Okay, this is whole blood. But filtrate comes out of the plasma. The glomerular filtrate which is being formed, it's formed out of the plasma. So therefore we have to know how much is the renal plasma flow, because filtration will form out of the plasma. Renal plasma flow obviously will be half of this roughly. You know, the blood is made up of cells and plasma. So 45% roughly is the cells volume and 55% is plasma. So 55% of this, let's say it's in the range of 625 to 650 ml per minute. That's the renal plasma flow. So this much is plasma flowing through the kidneys every minute, and from this much plasma the glomerular filtrate is forming every minute. That's 125 ml per minute. And therefore how much is the filtration fraction? Filtration fraction is GFR upon RPF. This much plasma flows through the kidney every minute, and from that this much is the filtrate which is formed every minute. So 125 upon let's say 625 ml per minute, and that is approximately roughly 1/5 or 20%. 20%. So from whatever plasma is flowing through the glomeruli, through the kidneys, only 20% will be filtered out, and that's the filtration fraction. So remember, a substance does not get totally filtered out in one pass. Only 20% will get filtered out. Okay. So that's filtration fraction, and this is the these are the things related to the GFR. Next point is factors influencing the GFR. How the GFR can change. So what we can do here is, we will take one factor and then we will say what happens to GFR if this happens, what will happen to the renal blood flow and renal plasma flow, and therefore what will happen to the filtration fraction. Filtration fraction of course is GFR upon RPF. Okay. So, first factor, dilation of the afferent arteriole. If the afferent arteriole dilates, that means more blood will come into the glomerulus. So, renal blood flow will increase, renal plasma flow increases, but GFR will also increase. So more the blood coming into the glomerulus, more will be the filtration, and therefore increase GFR, increase renal blood flow, filtration fraction can remain more or less the same. Second, moderate constriction of the efferent arteriole. Just moderate constriction of the efferent arteriole. So let's have a diagram to visualize it. Here is the efferent arteriole. If it is constricted, what will happen to the blood flow and what will happen to the GFR? Look, first of all, renal blood flow will decrease and renal plasma flow will decrease, because blood flow is in per unit time, and if the blood going out per unit time decreases, because of the constriction of the efferent arteriole. If the blood going out per unit time decreases, then the blood coming in per unit time will also decrease, and therefore eventually the renal blood flow and renal plasma flow will decrease. When I say renal blood flow, actually we can take it as renal plasma flow, in the sense that we are talking about the rate of blood flow and rate of plasma flow. They will be the same. Now, yes, so renal blood flow will decrease in the efferent arteriole constriction. What about the GFR? GFR will increase. Why? Because the blood leaving the glomerulus now has become less. Less blood leaving the glomerulus because of the constriction. That means more blood accumulates in the glomerular capillaries. And remember, capillary hydrostatic pressure, more the amount of blood or fluid accumulated, more will be the hydrostatic pressure. So, if more blood is accumulating in the glomerular capillaries, capillary hydrostatic pressure in the glomerulus will increase, right? So, there will be increased glomerular capillary hydrostatic pressure, and here is a force that favors the filtration. So, GFR will increase. Let's write it down. In the moderate constriction of efferent arteriole, GFR increases and renal blood flow and renal plasma flow decreases. So, numerator has increased, denominator has decreased. What will happen to the filtration fraction? Filtration fraction will increase, right? Now, there is a twist. Look at the third influencing factor. Severe and sustained constriction of efferent arteriole. Severe sustained constriction of the efferent arteriole. Now, there is a change in the scenario. Look, if there is a severe and sustained constriction, what will happen is the plasma proteins which are there here in the capillaries, those plasma proteins are unable to leave the glomerular capillaries. That means plasma proteins will stay in the glomerular capillaries because it's a severe sustained constriction of the efferent arteriole. So, plasma protein concentration will increase in the glomerular capillaries. What will be the result? There will be increased plasma colloid oncotic pressure in the glomerular capillaries. And remember, here is a force that opposes filtration. So, that force increasing, that pressure increasing means GFR will eventually decrease. Remember this, there is a decreased GFR. And also the fact that initially when the constriction happened, when the efferent arteriole constricts, initially filtration rate had increased. So, that means more fluid came into the Bowman's capsule because filtration rate had increased, and less fluid or less plasma is staying in the glomerular capillaries because filtrate is formed, more and more filtrate was formed. So, less plasma in the glomerular capillaries, so capillary hydrostatic pressure in the glomerular capillaries, the glomerular capillary hydrostatic pressure will decrease because lot of fluid has been filtered out. So, less amount of blood in these capillaries over here, less amount of plasma I mean to say, and the fluid got filtered out and came into the Bowman's capsule. So, Bowman's capsule hydrostatic pressure will rise, increase, and that force is an opposing force, it will oppose the GFR. So, the end result is there is a decreased GFR. And of course, there is decreased renal blood flow and renal plasma flow, because less blood going out means per unit time means less blood coming in per unit time, and overall blood flow will decrease. That we have already seen. Let's write down. GFR decreases, renal blood flow and renal plasma flow decreases. So filtration fraction more or less will remain the same. Right. Let's take one more factor influencing. Just for the sake of understanding, we will take a factor like a nephrolithiasis. Nephrolithiasis, renal stones. What do you think will happen to GFR? What do you think will happen to the renal blood flow and renal plasma flow? And therefore, what will happen to the filtration fraction? So here it is. In nephrolithiasis, what happens is those crystals, the renal stones or the crystals, they will decrease the flow of tubular fluids. They will decrease the flow of tubular fluids. Okay. Which means what? Which means more and more blood, or I beg your pardon, more and more filtrate will stay in the Bowman's capsule, because it is not flowing down normally into the tubules. There is decreased flow of tubular fluids. So, more and more fluid, more and more filtrate stays in the Bowman's capsule. That means there is increased hydrostatic pressure in the Bowman's capsule. And now there is needless to say that here is a force that opposes the filtration. Therefore, GFR will decrease. So remember, in the nephrolithiasis, glomerular filtration rate will decrease. Renal plasma flow and renal blood flow is unaffected by the nephrolithiasis, and therefore filtration fraction would decrease. This ratio or the filtration fraction will decrease. Let's just write down here. Nephrolithiasis, GFR decreases, renal blood flow and plasma flow more or less the same. So filtration fraction decreases. These are some of the important factors. They can give you a case study or some problem and ask you to calculate what will happen in this particular case.